Well, as people are still joining, let's get started. Hello, everyone. Welcome to the launch of the Lown Institute's 2024 Fair Share results. My name is Vikas Saini, and I'm president of the Lown Institute. We're so glad to have you all here, and we're here to share some exciting information about hospital community benefits. Coming up, we'll be showing you our fair share results, both for hospitals as well as hospital systems. We'll be diving in a little bit with some California-specific data and even more. So for a little background, we study community benefit spending as part of our larger work evaluating hospital social responsibility. This will be our 5th year of publishing a unique ranking, the Lown Hospitals Index for Social Responsibility. The final tally will be published in June. We created the index because we wanted to measure more of what matters to patients and communities, not just outcomes, which many people report, as do we, but also value of care and health equity. So we use metrics that have never been used before, like racial inclusivity, avoiding overuse, pay equity, and our topic today, community benefit spending. Now, hospitals are obviously vital to all our communities, particularly if we want our communities to be healthy. But let's not forget that they have become in the last 50 years, big businesses. Hospital spending makes up 30% of the nation's healthcare spending, so that's about $1 trillion now. And the largest nonprofit hospital systems in the US take in tens of billions of dollars in revenue each year, and they're often the largest employer in their area. So these aren't the mom and pop nonprofit down the street anymore. Yet we see a paradox when it comes to hospitals and health, in which people in some neighborhoods, right next to the hospitals, actually have worse rates of chronic conditions such as diabetes, heart disease, or mental illness compared to those living in the broader area. Communities are contributing their tax dollars to their local hospitals, so it's important to know what they're getting in return. Most hospitals in the US are private nonprofit hospitals, so they're exempt from federal, state, and local taxes. In exchange, hospitals are expected to invest in ways that improve community health and further their social mission. Things like giving free care to patients who can't afford it, providing needed services like substance abuse treatment, behavioral health, and even investing in social factors like affordable housing or food security. Hospitals have to report their spending on these activities to the IRS on the Schedule H of the Form 990. And it's through analyses of these forms that researchers like us have gotten a better sense of how hospitals are giving back to the communities. And you'll see that in the results coming up. But before we dive into all of that, let's introduce our guests. Anthony Wright is from Health Access in Sacramento, California, where he's served as executive director since 2002. Wright led California's coalition effort to help pass and then defend the Affordable Care Act and countless state healthcare reforms. So Anthony, tell us a little bit about Health Access California, what it does, and one thing that you're focusing in on right now.
Hi there. My name is Anthony Wright. I'm the Executive Director of Health Access. Thank you, and happy to be here. We're the statewide healthcare consumer advocacy coalition working for the goal of quality, affordable healthcare for all. And this year, we're working to continue to expand coverage and affordability, whether it's expanding the affordability options and subsidies in covered California, or opening it up to include every Californian, regardless of immigration status, as California has done in Medi-Cal. We're also working on a variety of efforts to control healthcare costs and improve value, and we'll talk about some of that later in this discussion.
Great, thanks, Anthony. You're a busy guy. Dr. Michelle Burton currently serves as the CEO for Rising Communities. Based in Los Angeles, Rising Communities works for policy and systems change, including issues like health equity, reparations, and economic resilience. So, Michelle, what else should we know about rising communities? In what ways does your work connect or intersect with hospitals?
Thank you, Vikas. Can you all hear me okay? Wonderful, thank you. So Rising Communities was founded in 1992 out of the LA uprisings. The goal was to work in community with residents to identify community problems and then work collectively with those residents to identify and then deploy those solutions to ensure that folks were included in the process of decision making about important funding decisions and other needs that they may be facing. Because of course, the uprising had much to do with their particular needs being unmet. I was 16-year-old at the time, so I certainly remember not feeling very heard in my community and participating in some of those town hall discussions even then. So the work at Rising Communities continues to intersect, with that same work that I've been doing since I was 16. It's bittersweet to say that, I'm 47 and I'm still working on the same issues in the same communities. And so the way that our work intersects with hospitals is understanding the role that hospitals play, which is extremely impactful. When the absence of hospitals is felt in our underserved communities, that absence is extremely impactful. And so the little support we receive in our communities from the presence of hospitals really has to be maximized. And I think that's what the conversation is today. It's about how do we maximize the support that we may be able to get from our current existing medical centers, which are few and far between, again, in medically underserved communities. Thanks, Vikas.
Thanks, Michelle. When I came back to the Harvard area after being in a community hospital and started work at Lown, I've been hearing for a decade about the need to incorporate accountability to communities, the community voice, community guidance. So it just sounds to me, I don't know enough about your organization, but it sounds to me like you're an exemplary organization for precisely that. So we're delighted to have you here. Joan Allen is a government relations advocate for SEIU United Healthcare Workers based in Oakland, California. She currently covers issues related to healthcare, health insurance, COVID-19, and elections. So SEIU United Healthcare Workers represents approximately 100,000 California healthcare workers. Joan, you have an interesting perspective because your union members both work within healthcare and use the healthcare system. You want to tell us a little bit more about what that perspective brings?
Certainly, thank you. And thank you for the opportunity to join the conversation today. Again, I'm Joan Allen, Government Relations Advocate with SEIU United Healthcare Workers. And that's within the larger umbrella of SEIU, which is a labor union representing more than 700,000 workers across California. Within that, SEIU-UHW represents about 100,000 healthcare workers, the majority of whom work within the nonprofit hospitals and health systems that we'll be discussing today. Our members include allied health professionals such as respiratory therapists, medical social workers, housekeepers, licensed vocational nurses, and just the range of professionals needed to operate a hospital or health system. In many cases, it is my members who are providing some of the community benefits that we'll be discussing here today. We see that position within the healthcare system as an important one, where we are bringing the voice of working people who are both healthcare workers and patients and consumers. And so we have been engaged for many years in efforts within California to increase transparency and accountability within the healthcare system and to support policies that will make the system more affordable and accessible for Californians, while still recognizing that that healthcare workforce needs to grow and flourish in order to serve the California not only of today, but of the future. And we see much more that our hospitals and health systems can be doing, and are happy to support efforts to, like the Office of Healthcare Affordability within California and others, to improve the system from a systemic level, rather than trying just with each of our employers to improve one step at a time.
Great. Well, thank you. And again, thanks for joining us. So for all of you, excuse me, we want to get your take on why the issue of hospital community investment matters from your perspective. So we previously mentioned some of the ways that hospitals give back to improve community health. In California, and really in all states, there's a great need for more investment in health and social conditions to close some of the disparities that we see. Here's a map of the CDC data on life expectancy by state. And when you look at that, California has an overall life expectancy of 81.3 years, which is good compared to many other states. But if we zoom in all the way down to LA County, which is what you see here, there are differences as high as 10 years in life expectancy between tracts that border each other. So let's just think about that for a second. That's 10 years of life with half a mile of distance. So what's 1 year of life worth to any of us? Multiply that by 10. That's almost unbelievable, but it is one of the ongoing tragedies all across the United States. Michelle, we see these differences in life expectancy all over the US, but what does it look like in LA? What are some of the big health and social problems you see affecting the people that you know?
Thank you for that question. One of those little red specks in there is actually the community of Watts. And I've been tracking the life expectancy of Watts for at least the last decade when I really started to look at, what does the data tell you? I always say I'm a baby PhD. So this was early in my researcher path of really starting to understand what can we learn from data? How can it drive, solutions to these really, really pernicious problems? And in looking at that, it became really clear about where some of those disparities are, right? What were the leading causes of death? And some of them were in that category of preventable diseases. So when you see things like preventable diseases driving these life expectancies, then you turn to the healthcare system, which we all, I think at this point, agree is broken. We're working collectively to fix it. And the hope is we're working with our medical systems, our hospitals, our providers, that we are looking at this as a collective problem in our communities, and how can we work together to solve them. And so the issue that we're talking about today, I think I want to again make sure that we see it from the lens of not trying to find bad actors, but rather trying to identify opportunities to work together towards these solutions.
Thank you, Michelle. Joan, do you have a quick comment?
We come to a lot of our work from a justice frame. And within healthcare justice, that is the idea that we are trying to help the entire person. And so providing affordable and accessible care that people can reach in their communities. Because when you showed that map of Los Angeles, that's where my members live. They are parts of these communities, and they may work at the fancy hospital, but they're going back home to Watts. They're going back home to the parts of Los Angeles where air pollution is causing major health harms, or where there are local healthcare deserts. And so remembering that there is that interaction between the healthcare system and the people who are then providing care within it is just an important frame to start with.
Thanks. So Anthony, I'm going to turn to you in a second. Hospital spending also matters when it comes to other things like medical debt, because hospital policies dictate who's eligible for free and discounted care. Often that can make the difference between a patient going into debt or not. I think more and more people recognize that medical debt is a huge problem in the United States, with over 100 million people having some form of it. The red on this map represents a share of people with medical or dental bills in collections. The darkest red color indicates that more than 40% of the people there have debt in collections. Hospitals do play a role here because much of the medical debt is owed to them. Even in California, which has amongst the most progressive policies in the nation around financial assistance and medical debt protection, debt is still a major problem. 9% of Californians owe medical debt, according to the CFPB, totaling $7.5 billion. And 1 in 10 people in LA have burdensome medical debt, according to a survey from County Health, the public health department there. So, Anthony, are we overstating the case here? Is this a problem? And what's your view on this? What's being done about it?
We're not overstating the case. Medical debt is real. It has a real impact on people. It has a particularly pernicious effect because it tends to be a bill that is maybe unexpected. Comes at, it's not something that you necessarily plan for if you have a medical emergency. It's also a situation where, by definition, you're going through other things in your life, and then it compounds that you have this big bill. And a hospital bill is typically the biggest bill anybody will get in their entire life. It is, folks who have not had the opportunity to engage the hospital system, I think, are always shocked at how big it is, how big the bill is to stay even a day or two in a hospital, or otherwise get services from it. Hospital debt is reported to be around 70% of medical debt, and so it's an important place to look when you're looking at this financial stress on communities. So when we talk about the community benefit of hospitals, I come from a basic baseline of, let's first start about the concept in medicine of first do no harm. That hospitals are so incredibly important, so vital institutions that we depend on so much. But let's also make sure that they're not contributing to some of the problems by adding medical debt and frankly financial stress to our communities, including the communities that were in deeper red on your chart, because that's where it's disproportionately impacted. You mentioned that 1 in 10 stat in the LA of significant burden. The California Healthcare Foundation has a survey that suggests that 38% of Californians have some sort of medical debt, and again, that is disproportionate in Black, Latino communities, in low-income communities. I mean, even amongst folks that we don't necessarily think of as having debt, like those on Medi-Cal, which generally has no or little cost sharing. So people are, maybe it happens when they have gaps in coverage, maybe it happens on things like dental or mental health or other circumstances. But this is a significant issue that we need to address.
Thank you. We've been looking into this, and we'll have more to say later this year on this, but I was talking to a friend of mine, a clinician in a fairly large clinic, asking about that, and he agreed to, ask around and find out more. So he asked the workers in his own clinic, if they knew anybody that they could refer to him who had some significant amount of medical debt. And he was embarrassed and flummoxed when a third of his own people raised their hands. So, Joan, it's very ironic when health workers can't afford health care. Is this happening to your membership?
So a fairly common reason that workers will seek more of a voice on the job and seek to form a union is issues related to compensation, including issues related to health insurance costs or medical debt. And so this is constantly a conversation that workers are having with their coworkers, and is something where we work very hard at the bargaining table to ensure that our members have fully paid family health care whenever possible and have good access to care. So that is a huge part of our work. We also, as healthcare workers, are seeing our patients showing up later and sicker than they should. People coming in through our emergency rooms, and it's an issue that could have been dealt with earlier, but they were so afraid of the debt. They were so afraid of the bill that they held off as long as they could, hoping it would get better or hoping they'd get a job with benefits. And so we are seeing that. Our surgery schedulers have to deal with people who are afraid to schedule a surgery because they know what the bill is going to look like. We also have within our membership some of the clerks and billing staff who talk patients through their bill.
Yeah.
And that is, we see that problem every day. And even within our members who have good health insurance, there can still be that surprise. There can still be that durable medical equipment that isn't covered or a family member's bill. And so, yes, within our members, that is incredibly important and only becoming more so.
Thank you, Joan. I mean, we could talk about this at length, but really, this is a topic for another day. So I want to move on. Michelle, is there one thing you want to add to the medical debt question in LA in particular? And then I'll present our data.
Yeah, thanks, Vikas. I'll just add this. I think that the reason we're having this conversation is we finally have reached the critical point where it's ridiculous. I always say, you know, policies happen when we realize how existing policies have just gotten to be ridiculous. And in this ridiculousness, there are a lot of great minds coming together, a lot of recommendations around how we can, you know, improve this for the consumer, none of which include the opinion I'm going to give, which is we should forgive it all. And we should have universal care. If we can't have universal care, we should still forgive it all because nobody's going to prison over their debt and nobody should have to choose paying their medical debt over feeding their families or paying their mortgage or their rent.
Thank you. Well, so let's talk a little bit about some of the data at Lown. How well did hospitals do in terms of helping solve problems through community investment? Are hospitals paying their fair share? Let's take a look at the results. So we looked at tax data for more than 2,400 hospitals, compared the value of their tax exemptions to their spending on community investments. We focus on certain categories of spending on the IRS Schedule H, most likely to have a direct and meaningful impact on community health. We include financial assistance, which is free and discounted care for eligible patients, community health improvement programs like immunizations or health education, subsidized health services, things that might not exist without the hospital, even if the hospital is not making money on it, like behavioral health or substance abuse treatment, contributions to community groups, and community building activities, which are designed to tackle many of the social drivers at the heart of poor health. So let's look at the categories we don't include. These are important and generally valuable and are clearly social and public goods, but they don't have a direct and meaningful impact on their local communities. Those categories are also susceptible sometimes to multiple counting or double dipping, if you will, meaning hospitals can choose to claim those expenses in multiple different circumstances. Medicaid shortfall is the difference between what hospitals receive in care for Medicaid patients and the cost of that care. It's very important that hospitals take care of patients covered by Medicaid, which is really an insurance program like others. But hospitals make up for this shortfall by charging privately insured patients more and by receiving other payments, including disproportionate share payments from the government, not to mention subsidized pharmaceuticals that they can sell at list price and pocket the difference. That's the 340B program. So when you add all those up, there's a substantial revenue stream from Medicaid. Health professionals' training and research are certainly public goods, but the way these programs are run, they aren't really targeted to address specific community needs, particularly the workforce. If they were, we'd see a lot more primary care doctors getting trained, wouldn't we? All the categories we include, we put on one side and compare those to the tax exemption. So we estimate the tax exemption value as 5.9% of expenses based on academic research. So if hospitals receive more in tax breaks than they spend on community investments, we call this a fair share deficit. If their community investments exceed their tax break, well, that's a fair share surplus. So overall, we see that 80% of hospitals did have a fair share deficit in 2021. Counting up the deficit of all these hospitals, that's a combined amount of nearly $26 billion. So here's some of the hospitals with the largest deficits in 2021. Stanford had a $181 million fair share deficit. You can also see they ended the year with $1.3 billion in net income. In fact, almost all these hospitals had net income higher than their fair share deficit, meaning they could have closed their deficits and still ended up in the black. And here are the top systems for fair share deficits. It's the first year we've included Kaiser, and they have the largest system deficit in the US. In dollar terms, that's not a surprise. They're the big system. But we also noted that 5 of these are Catholic systems. These 5 alone make up about 15% of the total deficit in the US. And Catholic systems all had their origins, as I think we all know, in a deeply charitable mission. So I think it's ironic. Now let's look specifically at the state of California. Here are the top deficit systems for the state calculated by including just their California hospitals, excluding any others they might have. And so clearly Kaiser's at the top of the list, but we also have some big names like Sutter Health and Cedars-Sinai, as well as the Catholic systems we saw previously. So in our analysis, we found that on average, hospitals spent 3.87% of their budgets on community investment. But this proportion varies widely. For example, Kaiser spent 1.53% on community investment. If they'd spent up to the national average, that would have been over $600 million more in community benefits spending. So what do you think of these results? If Kaiser had spent $600 million more in 2021, what might that have been spent on? What could that have done? I think it's a question for all of you, but again, let me just start with you, Joan. We saw some big fair share deficits. How do we think this is going to happen going forward, knowing that in 2022, it was a difficult year. Labor costs were rising. There were shortages. There was a lot of difficulty. And 1 in 5 California hospitals were reportedly at risk of closure. So these are 2 opposite things. How do we make sense of that? Can you help us out?
Well, I really appreciate the data, and it is incredibly disheartening to see those gaps and to see those large systems not really meeting the moment in terms of supporting California families. And 2021 to 2022, yes, 2022 was a difficult year, but much of those that swing that you talked about, where we've heard the claim that 1 in 5 California hospitals is in substantial financial danger, a lot of that swing was because those hospitals had not fully invested in their community and in their workforce. We saw contract labor costs rising extremely quickly, whereas worker salaries for employed workers were not. And we also saw systems where it was more, those losses were more due to the stock market. So we weren't seeing that increase in investment in their community. But these results are not particularly surprising to me. There is so much more that California hospitals could and should be doing. And to see those large systems not really pulling their weight is incredibly frustrating.
Yeah. Well, Anthony, you know, at Lown, we're well aware as we look through all the data that there really haves and have-nots. You know, it's not really one size fits all when we start examining these questions. You know, hospitals that are at risk financially are hospitals often that are greatly valued and valuable in the communities they serve. And it is often the case that you could have a situation where Some hospitals have fair share deficits, others have surpluses. Some hospitals are at risk of closure, others are not. From a policy point of view, how does one take into account the fact that there's such a spread in conditions of these different hospitals? I know it's a complicated question, so maybe it's unfair, but I want to ask you.
Yeah, no, I think it's an important question, right? Because there are again, hospitals are vital to a community, but with great with a great responsibility comes a need to be responsive to the community. And one of the things is, what can we do to support those hospitals that are struggling, but also recognize that there's a lot of hospitals that are doing well, that have rebounded from the pandemic, and have those margins that you talked about, and have the opportunity to invest in community, in some of these public health and other efforts that can actually make the system better for all of us. And again, just to even go back to just match the fact that we have this, we have these margins, we have this fair share deficit, as I think you've identified, while at the same time that some of these same institutions are putting people into medical debt. And at the very least, can we apply apply some standards, some effort to prevent that situation where the hospitals are actually creating a financial burden in the community with their pricing and billing practices. That doesn't mean that we shouldn't also be doing things like here in California, we set up a distressed hospital fund, which we supported, and to support those hospitals that were in some distress. Those hospitals tend to be ones that are in communities and trying to take care of communities under some tough circumstances. But again, there's a lot of other hospitals that I think can be contributors to the solution. The other thing I would just say about your overall analysis is that I think it's helped to put some definitions on an ongoing discussion that we've had in this healthcare space for years, right? The question of what is the expectation of hospitals, especially those that are getting significant tax breaks, and to actually tally up what those tax breaks are. There's an argument that you might have even undercounted some of those benefits, and then to tally up what is actually given. And again, I would make the case that there is some real debate about both the definition of the word community and the definition of the word benefit. There's some things that are as much marketing as they are investments in the community, but I do think that actually doing the math to sort of figure out what is being given and does it meet the expectation that we have for our hospital system, for our health system, I think is incredibly important work, and should help generate the discussion of what more we can ask of our health system to meet the needs that we clearly have in the community.
Great, thank you, Anthony. I think the topic of how and who defines community benefits is something we're going to need to turn to. And Michelle, I'm going to ask you to lead that. But before we do that, the earlier question, like how we tally things up, I think is probably worth exploring a little bit. So up to now, we've been discussing the results that use the method that we described previously. But we're excited to announce that we're in the middle of a 2-year project. It's funded by Arnold Ventures, where we're using more precise tools to calculate hospital tax exemptions. So joining us now is Judith Garber, Lown Institute Senior Policy Analyst, and she's going to share some of the insights from this project that is just getting started. Judith?
Thank you, Vikas. It's great to be here and share a bit about this upcoming project. So with this initiative, we're building on previous research to get more detailed information about the hospital tax breaks. So rather than use our average rate of 5.9% to calculate the tax exemption, we're actually going to be looking at individual income tax, sales tax, value of tax exempt bonds and donations, and even real property values from county assessments. So over the next year, we're actually going to be looking at hospitals across these 20 states. but let's take a look a little bit at California now. So for this project, we're calculating all parts of the hospital tax exemption, including federal and state income tax, property tax, like I said, all those value of tax exempt bonds, etc. And usually we would include the sales tax exemption, but in California, nonprofits don't have a special exemption for that, so we've left it out. And breaking it down by category, California hospitals benefit the most from income tax exemption, but high property values in certain parts of the state also play a role. And on the community investment side, so California hospitals devoted less to financial assistance than in other states, which makes sense because they have a high rate of coverage. So with the money they're not spending on financial assistance, where are they spending that on? Compared to other states, California hospitals spend more on cash and in-kind contributions and on community health improvement programs. And so we want to show you just a couple of case studies comparing two hospitals in Los Angeles using this precise method. It'll be MLK Community Hospital and Cedars-Sinai Medical Center. So with using this more precise method, we can really see these numbers come into sharper focus. And the biggest difference here between these hospitals is how much income they had in 2021. Cedars made close to $1 billion, while MLK made under 20 million. But you can also notice that Cedars avoided nearly 30 million in property taxes, and they received 65 million in benefits from tax-exempt donations. And compared to MLK, which does not actually have exempt property. So in the end, when we look at this with the precise method, you can see MLK giving back 30 million more than their exemption, and Cedars gives back 200 million less. And so something this kind of project has revealed is that sometimes the fair share deficits are actually much lower than we thought, and sometimes the fair share surpluses are also lower than we thought for these safety net hospitals.
Great. So let's go on, and maybe just a question to you, Judith, first. You know, why is the struggling hospital that serves mostly Medicaid patients giving back more, while a hospital that seemingly has plenty of resources is really not? What's going on with that, like structurally?
Yeah.
Do you have a...
Yeah, so it's not that, some hospitals are being really bad actors or, doing anything illegal. They're really behaving completely rationally given the incentives that are in the system. So, for example, hospitals have to report community benefit spending to the IRS, but there's no minimum amount in almost any state that they have to spend. And they have to conduct a health needs assessment to identify what are the really most important health needs in my community. But there's no link to then say, okay, and now you have to spend X dollars to help address those problems. So really, we don't have enough accountability to make sure that that hospitals are spending what we would expect them to.
Thanks. Michelle, you want to comment on that, as well as the broader question of how we define the health needs and community benefit spending that's meaningful? And then we're going to turn to audience questions, because I'm sure we have lots.
Of course. Thank you for this. What we need, and you alluded to it earlier. Sorry, it's like allergy season has begun. I can't take enough medicine. Is the community-led private-public partnerships. This is how we have to start addressing these really structurally flawed systems. So you have policies that are incomplete. They have no enforcement mechanisms. So although there is a community benefit statute, there's no teeth in it. So we have to come back to, again, community-led public-private partnerships to start talking about where these deficits are, where these flaws are that are harming communities, so that we can, mitigate that harm, right? That's the simple answer. One example is there's a bill right now out there in the assembly around, taking medical debt off of people's credit reports, right? So that's a great step. It's a great acknowledgement of something that's ridiculous, punishing people for being sick. So if we can continue to do more of that, we can find solutions. And I'll leave you with this. LA County, under the leadership of Dr. Barbara Ferrer at the Department of Public Health, has launched a wonderful community public health teams pilot that models some of the best practices of community-based health systems in places like Costa Rica, right? So in the next 5 years, that alone could be, demonstrative of some of the ways in which we can improve how we are working together, because that model is inclusive of community voice, of the health systems, and the hospitals will hopefully get involved in the next few years of this pilot. And so again, I think there's huge opportunities to bring community into the conversation so that we can, remedy these flaws, right? There's no minimum community benefit. Let's work on that. And I think as long as everybody's willing to come to the table and have a conversation, we can move forward, which would be wonderful.
Thank you. Thank you. So we have a lot of audience questions, and we don't really have enough time, but let's try to.
Vikas, I think you're frozen. Does anyone else see frozen? No. Well, while he gets unfrozen, oh, you're back. Vikas, you were frozen for a minute, so we didn't hear the audience question.
Oh. Huh. Oh, well, I guess our internet provider will have to hear from us. So audience questions, is that where I was cut off? Okay.
Yes.
This is for you, Anthony. Lots of problems people face, such as medical debt. But is the nonprofit hospital the only organization that really is responsible for all this? What about all the nonprofit insurance companies? After all, some of these benefit designs are at the behest of employers that insurance companies implement, that hospitals simply participate in. And the net underinsurance is driving lots of these problems. So can we be an equal opportunity finger pointer here? What's going on?
Absolutely. I mean, I think there is an opportunity to look at the whole healthcare system and try to relook at the incentives that the system has in place now. We know that the Affordable Care Act took a big step of removing some of the negative incentives that were in place, the incentives to deny people for pre-existing conditions, charge them differently, the game of hot potato that where health plans or other providers actually do better when they avoid sick people rather than actually treating them and providing the best care. But I think we have to do more about positive incentives to actually get to a system where people are incentivized to provide quality, value, equity, where people actually get the right care in the right place at the right time, which right now is sort of, according to all the data, like a 50% chance that will happen. And that's not because, as Judith said, of some heroic people within the system trying to do good work, but they're doing it within a system that's not actually geared toward that. So I think that's there, and this state is trying to do that both trying to complete the work of getting everybody covered, both implementing and improving upon the Affordable Care Act and getting to that goal of universal coverage and having multiple conversations in a variety of ways, whether it's the vision of a Medicare for all single payer system or whether it's the work of just even expanding our current public programs. But it's also the efforts like things like the Office of Healthcare Affordability and putting a broad goal target for the system with regard to cost, looking at quality and equity, and trying to again, change the fundamental incentives of our structure. That it's not just to get bigger, but it's also to get better, and that's there. But that doesn't. But the need for those broad sweeping efforts that we're actually undertaking doesn't obviate the need to actually look at what each system is doing themselves with regard to community benefit. What could they be doing to actually provide upstream help so that all the problems don't arrive on their doorstep in the emergency room? So I think that yes, we can point fingers in lots of different places, but for this conversation, I think it's worth talking about hospitals, which are typically the largest employer in the community, which are typically one of the biggest institutions that is supposed to be focused on public health generally. And that's what is the usefulness of this fair share index. And now you're muted.
A number of audience questions are really about some of the methods. And so I'm going to toss these to you, Judith. And for the whole panel, you know, the remainder of today's session is really going to be focused on, you know, what can we do? What kinds of solutions might there be? But I think it's all just going to blend together now. So let's just go, we'll all be freelancing a little bit. So Judith, here's a few questions. One, when nonprofit system functions as a holding company and there's for-profit subsidiaries, are those subsidiary revenues considered when calculating fair share spend on the nonprofit parent? I will confess, I hadn't thought of that. And I'm not sure we have the data because almost certainly the for-profit revenues are going to be reported maybe to the accountants and on the financial statements of the hospital, but probably not on Schedule H. But what do you know, Judith? Can you
Yeah,
shed
just that we're going by the tax form. So generally, I would think for-profit subsidiaries would not be included. And you can see on like Schedule R, it'll also list some for-profits that they're affiliated with, or maybe that they're the parent of, but they're not included.
Yeah. And I mean, that cuts various ways because the for-profits presumably are paying taxes, so they would
Yes.
want to give them credit for that, right? Another question along those lines, what type of data should we require hospitals to supply if we're going to have more transparency? I know you've thought about this a lot.
Yeah, and I just want to put, so we also put together a policy brief that goes into some of, you know, what I would say like my dream list of policies that would be great to have to get to know more about exactly what hospitals are spending on. And some of it relates to what Anthony was saying about, you know, some of these activities are not really designed to actually address these priority community health needs. They're more like marketing activities. But what Massachusetts has done for the past several years in their reporting is that they ask hospitals to only report spending on community benefit programs that address those specific community health needs. It can't be just something that you wanted to do that's unrelated to one of the important needs that you identified. So having that broken out, I think, is incredibly important. And there is, there's already one state doing. I think other states are interested in getting more at like, what are we really talking about for community benefit here?
Yeah, and here's a really quick, I think, short answer. The uncompensated cost of care, how does that relate to community benefit? Is that measured separately? Is that included?
So usually, uncompensated care is seen as financial assistance plus bad debt. We do include financial assistance in our categories, but for bad debt, we do not include. So bad debt is what hospitals write off as they were hoping to get this from patients. They billed patients, they were hoping to get it, but they didn't get it, or the person didn't apply for assistance. But I think there's a very important difference between a patient that could apply for financial assistance and could receive it versus a patient that maybe is eligible, but the assistance process is just incredibly burdensome and hard to get, or they're not eligible for it, so they don't receive it. And I mean, a lot of the bad debt that they report, some of it may go to collections. So it doesn't seem right to put that in under a community benefit.
Great. So let's talk a little bit more about various pathways to fixing these problems, or at least improving things. Joan, do you have a view on what more we need on data and transparency when it comes to these questions of community benefit and medical debt?
I think this conversation has really started down that path. As healthcare entities are getting so much more complicated, the unit of analysis of the Schedule H being the hospital becomes a little bit less complete of a picture. So whether you have a hospital that is part of a 30 hospital system that also has an insurance plan and multiple for-profit affiliated joint ventures and subsidiaries, looking at that with the hospital, the nonprofit hospital as the unit of analysis just is not going to capture Or as we see sometimes here in California, if you have a hospital system that only has 2 or 3 hospitals, but one is in a wealthy part of town and one is in a much less wealthy part of town, and yet they are blending their community benefit. When you start unpacking it, a disproportionate amount of that community benefit may be spent in the part of the community that does not need it as much. And so you leave a disproportionate amount of unmet need. And so really getting better data that encapsulates the entire system and all of those interactions. And then also, as Michelle mentioned, the community needs assessments, those are much more narrative documents than really an enforceable contract with the community. And we often see, we read those and they read like marketing materials. And so getting to the point where those community needs assessments really are a real understanding of the needs of the community and a commitment by the hospital to hold up their end of the deal of getting these tax breaks. So really on the transparency side, there's so much more to do. But those are the two things that I would highlight are getting at the system level and then also improving the community needs assessments.
Right. So Michelle, how do we make it that the community needs assessments and the sort of way in which they're derived are truly driven by the community and its needs?
I think there's a couple of ways to do that. I mentioned the community public health teams earlier. So these are partnerships. There's 10 of them across the county. It includes community-based organizations, federally qualified health centers, and then community residents as part of coalitions that get together to identify how to tackle disparities in their communities, right? What are the needs? How do we reach out to people? They're doing, 8,000 to 13,000 homes, knocking on doors in each of these 10 community public health team partnerships. So you're looking at thousands and thousands of points of data represented through these, voices of community residents in partnership with the county, in partnership with, their FQHC partners. This is comprehensive, right? This is the definition of addressing complex social problems. And so I'm excited to see where that's going to go. I think that's one example. I believe another example is in Florida. They had issues with needing more funds to close disparities around young children, and they formed a special district. Special district allows a coalition of people, often intersectional again, residents, organizations, maybe members of the municipality in that area. And the funds are then given to the special district. They govern it and they make decisions about how it's distributed. That might be one solution to the community benefit dollars. And then the last thing I'm going to say is one of the common themes amongst the questions I'm reading and in even some of the feedback around the data so far is that nobody feels like anybody should be punished for, the debt or for the cost of giving care. We all agree on that. So how do we find a solution where the little guy who's the consumer who's been sick doesn't have to be punished for getting sick, and where the people who took care of them aren't punished? So there needs to be a universal solution, not one where winner takes all, right?
Yeah.
So that's what we're talking about. Where's the mutually beneficial solution to this problem?
Yep, great. Love that. Thank you. Thank you. So Anthony, I think you are in Sacramento. You have a sense of what's possible, what's coming down the pike. What solutions are being worked on now, whether it's on community benefit issues or medical debt itself, and what might be possible in the next year or in the next few years?
Yeah, I think certainly at the local level, there's a lot going on in a lot of different areas. And at the local level, Health Access is proud to be in coalition with Rising Communities and West Center Law and Poverty Children's Partnership, RIP Medical Debt, and others around that report that the LA County put out on medical debt. There is an active conversation about buying the medical debt, that the $2.9 billion that Angelenos have in medical debt and buying that off for pennies on the dollar to sort of free those families from the financial trap that our system has put them in. And that's a number of other both state and localities have been going down that path, and that's a really interesting conversation. I'm as if not more excited about putting in place policies that prevent the debt in the first place. And so there's that work both at the local level with regard to what kind of standards that could be placed on both charity care, financial assistance policies, billing collections policies for hospitals at both the local and frankly at the state level. With regard to at the state level, there is on this subject, one of the bills is the one that Dr. Burton mentioned, the one on making sure that medical debt does not incur on people's credit reports. That is SB 1061 by Limon. By Senator Limon, that we're a proud co-sponsor of that legislation and would like to proceed with it. Another one is one about providing updates to our hospital fair pricing policy. That's AB 2297 by Assemblymember Friedman. We were proud to pass the Hospital Fair Pricing Act, which said that uninsured or underinsured patients should not be paying more than what big health plans pay for exactly the same service, where typically they actually were charged 3, 4, 5 times because they're getting the sticker price rather than the negotiated price for the same policy. This update would put some make sure that there's no arbitrary deadlines for people to apply for that financial assistance or fair price, that there's not liens on people's houses, clarifying that was original intent of the bill, making sure that we're not including assets or in the calculations. Just because you have a little bit of retirement savings or a home doesn't mean that you shouldn't get a price that's aligned with what Medicaid or Medicare pays, rather than this 3, 4, 5 times sticker price that nobody else in the system pays. And so that's a really important bill that's pending in the legislature right now. And then I'd say one final thing is that as much as there are issues in our healthcare system, we are concerned about the continuing consolidation of our healthcare system and how much it drives additional costs onto all of us, both whether we're individual payers, whether we're paying through our deductibles, or as it sort of inflates the costs that we pay in premiums or in taxes, et cetera. And so we need to be mindful of that, and especially of the entry of actors like private equity that can have a really pernicious impact on the ecosystem of how hospitals operate. And so there is a bill, AB 3129 by Assemblymember Wood, to have greater oversight over that. So those are 3 specific bills that are pending now. Obviously, this is an ongoing conversation about, but those are 3 things that we can do this year in the state capitol.
Thank you. Well, in the time we have left, I want to stir the pot up a little bit. To establish my street cred, let me just say, in the late 1960s and early 70s, I was part of small discussion groups talking about this thing called social drivers of illness and disease that has now morphed into a huge academic area, frequently shorthand of which is social determinants of health. And now we have commercial determinants of health, and we have community determinants of health. But really, I'm old school in a certain sense. I mean, come on, is it really the hospital's job to make sure that housing is okay, that food security is okay? Aren't we actually, and I feel from my colleagues in the emergency departments around the country, aren't we basically just abdicating a social responsibility as a society and letting the healthcare system pick up the pieces? Is that actually how we want healthcare to function? Aren't we going to medicalize things that really shouldn't be medicalized? So what's your take on all of this? We expect hospitals to do certain things, and rightly so. But is this a bridge too far? Shouldn't we be thinking of other ways of doing it and maybe funding it through a different stream, or maybe some common stream of revenue? Anybody want to take that first?
Oh, I'll jump in real quick on that one. I'd say it's yes and. Part of what we're discussing here is that deficit, because ideally much of that is done through taxes. But these hospitals are, in exchange for not paying certain taxes, making a commitment. And so if they are not currently living up to their commitment, then we have every responsibility to ask them to do more. And as Anthony mentioned, a hospital is often the largest employer, largest institution in a community. They are uniquely placed in many communities to be that hub that can drive innovation around social determinants of health, social drivers of health. And so long as we are asking them to do more in order to justify the revenue that they're receiving, the tax breaks they're receiving, then I think it's entirely fair to help guide that with state policy, through some of the legislation that Anthony mentioned that we're proud to be in coalition around, and to ask for the transparency to make certain that what they are doing is actually benefiting the community in the ways that we expect.
Great. Michelle, I'm going to fold another question into that and then let you respond. And that's from the audience, which is, the suggestion of public-private partnerships is an understandable one, but what about the vast power imbalance? How do you ensure that it's truly community-led?
Thank you for that. I actually was reading that question and was hoping I'd have an opportunity to answer it here. So we actually started a participatory grant-making program in 2021 called South LA Decides. I can say that, the reason, and I'm a broken record, the reason I decided to go back for my PhD was to understand, after 25 years of addressing these drivers of illness, these social determinants of health, these, structural isms, I wasn't seeing a lot of progress. And after spending a lot of time deeply thinking about it and researching and even looking at systems theory, early systems theory was about the intersection of disciplines. And how do you work at the intersection to affect positive systemic change? That was literally the forefathers of systems theory. That is what they wanted to accomplish by discussing systems theory and stewarding this. But unfortunately, it's been commodified by our capitalist system. And so when you say systems thinking today, people think Six Sigma, black belts, lean in, cut people off. And I think, oh my God, we've gotten so far away from the idea of how, the complexity of systems was supposed to help make us better. Instead, it forced us to become more reductionist in our thinking and how we address very difficult problems. So when we started our participatory grant-making body, it is completely resident-led. People advocated. They said, well, we should let the foundation sit on this body. We should let, we should have a decision-making, position. And I said, no. Because of that power imbalance, we absolutely have to turn paternalism on its head, which means nobody with that type of power can have decision-making power. We don't know how to behave yet, right? We're not ready. So you have to take us out of that system and allow the people who are truly impacted by those dollars and by those decisions be the ones who have the absolute autonomy to make those decisions about how that money is spent. They get to be the ones who look at the data and decide if things are working or not and how they might want to adjust. Our role is to make sure they have all the access to the information they need to make informed decisions. That is our role.
Great, thank you. Yeah, I completely agree. I've had this notion for a while. I've been trying to interest funders in it. Really, part of the imbalance comes from the complexity of the healthcare delivery system, and what we really need is a sustained effort at what I call health system literacy, not health literacy, not about what drives your sugar up and prevents amputation, but health system literacy. What drives good care, both at your hospital and in the community? How do the funds flow? Anyway, that's a long other conversation. There's a question from the audience that I'm just going to ask somebody from the staff to put a link in to a stat op-ed. We get this question a lot. There's a lot to say. Why don't we count Medicaid shortfall? And I'm sure the American Hospital Association would want us to also count Medicare shortfall. So there's a lot of technical issues that we could talk about, but I don't think we have much time. So I'm going to carry on with some other questions. Anthony, other states are looking at these questions. We focused on California today. There's a lot of ferment. We get calls from all over. And a lot of what's in the policy brief that Judith mentioned is actually simply us collecting things that are happening all over the country. These are really not, brand new ideas of ours. I don't think we want to claim authorship in that sense. Stuff's happening in Oregon. There's a lot of interest in Ohio, New York, etc. What advice would you give for folks in other states who are trying to take action on community benefit or other hospital accountability issues? What's your perspective?
Yeah, I mean, I think we learn a lot from other states, and we're happy to have examples like the Hospital Fair Pricing Act I talked about earlier, like some of the more broader efforts. I mean, as well. You mentioned this issue of where's the hospital's obligation. Where do we draw the line? And I think, just to answer that question as well, right? I agree that we don't want to medicalize everything. We certainly don't. We're finding here in our state, one of the things that we're trying to do innovative is do more upstream in our Medi-Cal program through a series of reforms called CalAIM, where it's not just some of the medical interventions, but some of the things relating to housing supports with regard to upstream interventions that we think actually would save money, but also, frankly, provide better outcomes and better experience for the patients. But it's been really hard to put those kinds of services into the health insurance framework. Those providers have never dealt with health insurance and reimbursements before. There isn't really the natural language between the two, and so that integration is hard. And so that's where the opportunity is, and some hospitals are doing this. I don't want to ignore the good work that's being done. The question is, can it be brought up to scale of efforts to where hospitals are partnering with community groups that actually know how to do it better than that, and providing the resource and the interactions to say, okay, we have a homeless issue in this area. We have a issues with regard to mental health. We have an issue with regard to childhood asthma in this area. What can we do to that actually has a beneficial impact? So hopefully at the end of the day, it's not a burden on those folks in the emergency room. Hopefully it's actually a relief that at the end of the day, that it's that we're dealing with the problem before it actually before it impacts the provider and those workers inside the system that are frankly beleaguered because our system is not well coordinated to these issues. But to the issue what can learn, I think we can learn on, like, how can we better do both, whether we called it whole person care pilot programs or whether we called it CalAIM or whether are the other names. I think there are lessons to be learned for other states. I think that there is also a lesson to be learned for looking at this issue holistically and saying, okay, this is what are we asking of hospitals? What are we asking, but of the other stakeholders in the healthcare system? Because at the end of the day, as my colleagues have said, it is a system responsibility, and so you need to both look at what is each institutions, including the ones that are the most financed and the most powerful, like hospitals, but also, but then how does that integrate with the other stakeholders in the system?
Great. Any final thoughts? Because believe it or not, our time is up. Joan, last word.
We talked a little bit about consolidation, and I feel like that is a moment where there is a real responsibility. As we're seeing nonprofit hospitals sold either into larger and larger systems or sold to for-profit operators, that is a place where historically California has taken a very active regulatory role through our Attorney General's office and would encourage other states to look at that as not a model of 100% where we need to be, but at least a first step down the path, because the healthcare system is just becoming so much more complicated and so much more consolidated. So see that as a direction to head. But overall, just so appreciate the conversation today and all of the work that the Institute has done to help shine a light on this important issue.
Thank you. Last thoughts, Michelle?
Thank you. Just, I hope that given the amount of interest in this topic, not just in California, but nationally, that this is, really representative of the beginning of a solution to be found. And that the hospitals that are being referenced see this as a call and an invitation into a much greater discussion around how we work together. I partner with several of the hospitals that are on that list. And I know that the individuals that comprise those teams that work in those community benefit departments are completely committed to having a positive social impact in the communities that they are serving. The intent is there. And now we just need to talk a little bit more about the allocation of resources.
Yep.
Thank you.
Thank you. Yeah, let me just say some of our biggest fans work in community benefits departments of hospitals around the country. So it is clearly an area that will continue to be front and center. So I haven't been keeping track of the chat. My notifications thing just says 99 plus. So I guess there's been a lot of activity there. I'll have to catch up later. But thank you all. Thank you all for joining us and participating. Thank you to our guests. Anthony Wright is from Health Access in Sacramento, California. Dr. Michelle Burton currently serves as the Deputy CEO of Rising Communities in LA. Joan Allen is a government relations advocate for SEIU United Health Workers based in Oakland, California. You can follow them and their organizations on X, formerly known as Twitter. As we've mentioned previously, we have a policy brief available that outlines our findings, as well as recommendations that we've gathered from work of others around the country. You can find that on our website at lownhospitalsindex.org, and that's on the Fair Share spending page. So if you want to stay up to date on all things Lown, including alerts on when we're releasing data and hosting events, make sure to subscribe to our newsletter, Hospitals on Purpose. Thank you all so much for coming to today's event, and we look forward to seeing you again very soon.